and welcome to a special Black History Month discussion hosted by the Birmingham Civil Rights Institute. Be mindful that the opinions expressed as a part of the Birmingham Civil Rights Institute presentation are solely those of the participants and do not express the views or opinions of their affiliates. I'm excited to be here today. My name is Dr. Nadia Richardson. I'm the founder and executive director of No More Martyrs, a mental health awareness campaign that seeks to build a community of support for Black women and girls. And the title of our discussion today is Do Not Oppress My Health. I'd like to go ahead and welcome our panelists for this interactive conversation. Please note that we want this to be a conversation. Feel free to post your questions and your comments in the chat box below. I'd like to welcome Dr. Amina Shakir, who's with the History and Political Science Department with Florida A&M University, as well as the Women's Studies program at Florida State University. I'd also like to welcome Ms. Hanatu Blake, who is the Director of Health Equity and Social Justice with the National Association of County and City Health Officials. Lastly, I'd like to welcome Dr. David Hicks, who is the Deputy Health Officer with the Jefferson County Department of Health. Thank you all for being here today. So again, I want this to be an interactive conversation. I'm absolutely excited to have each of you here with your expertise and your perspective. And I do want it to be interactive. So again, for those who are participating, please feel free to post comments in the question box below, and we will be able to get to those during the course of the conversation. Let's jump right into what we mean when we're talking about oppression and health, specifically as it relates to the Black experience. Let's start off with a very general question. What is medical distrust? Ms. Blake, would you like to jump into that conversation?
Sure. Medical distrust really is an effect of long-term racism, right? Medical mistrust is skepticism about the healthcare system. And many Black people, and particularly communities of color, have some sort of distrust or mistrust for doctors or health professionals because they haven't had great access to the quality of healthcare that they should have. They also have had horrible experiences with health professionals. And we know historically, America has a horrible track record on how medicine has treated people of color. When we think about the Tuskegee experiments that happened between the 1930s and 70s, when we think about Puerto Rico, where during that same timeline, Puerto Rican mothers of childbearing age were being sterilized in the name of population control. We see all of this as a narrative that people can't trust medicine. They can't trust the people who are in health professions. So we really need to be able to build trust, create communities, and create relationships that better connect our communities to health professionals.
How does this distrust that, as you said, is informed by a great deal of history, inform some of these concepts like John Henryanism?
What, should I jump in, or would you like someone else to?
You can go ahead and build off of that.
Okay. I think let's be clear about like what John Henryism is, right? It really is stemmed from the folktale of John Henry, right? John Henry is this Black man who has a great work ethic and has a lot of strength. He beats this steam engine in this competition, but unfortunately, right after this competition, he dies. And he dies because of physical stress and mental exhaustion. So this notion of, or this hypothesis of John Henryism really is stemmed in how stressful and damaging health impact is on how we always try to strive to be everything in spite of inequities, in spite of financial hardships or racial discrimination. And all of that leads to an increase of mistrust because people can't trust the health system or medical professionals in really protecting them in the spaces that they live, in the spaces that they work, in the communities that they are a part of.
Absolutely. Dr. Hicks, how do you see this medical mistrust impacting patient engagement with health departments?
Yeah, so it's really challenging. I know that for the past couple of years, we've been all going through this big pandemic, and there's been a lot of national polls that have tried to figure out how do you engage with people based on their perceptions and feeling, and how do we bridge that divide with the disparities. And one of the things that we've found is that the who people trust and where they get the information from, how they consume that, drives human behavior. And so, and I think also that the stakeholders that we traditionally thought of what the community would go to get the trust has changed, in the recent years. And so, how do you overcome all this? I think it starts with the basic education understanding. Oftentimes in the medical community, we have had a paternalistic attitude as we're engaging with communities as if we know best. So we have our own ideas and our own perceptions on what the problems are and how to fix the issues. And we need to completely dismantle that notion. We need to go into the communities and let them allow us to come in, whoever those stakeholders are, and have a conversation with the community to tell us, what are your thoughts? Why do you think this way? How have we let you down or not served you in the proper way? And that's the conversation that has to start first. In order to build trust, you have to have relationship, as the previous panels have spoken about. And that has to be on the terms of the community and not on the terms of the medical establishment. So it starts with communication and come with an attitude of humility and learning, like we're having a conversation now. Once you have those conversations, people can understand where one side's coming from versus the other, and then you can forge partnerships. So it's not you're coming into my community trying to tell me how to think and act and do. It's if you're a medical community and you have resources, well, the community should tell you how to implement those. How can it be done on our terms? And then if you empower the community, then the community can start trusting again.
Okay, so what you're talking about are maybe strategies towards cultural humility, cultural competence, and cultural responsiveness, which is always going to have a positive impact on the health of those who have been historically marginalized and disenfranchised by the healthcare system. Dr. Shakir, what I'm really interested in asking you about, and I think is so interesting about you being housed in a political science and history department, is we know now the trend is what we're seeing are entities that are truly acknowledging how systemic racism is embedded in our healthcare industry. We're seeing conversations like that take place with the CDC, with the American Medical Association, with the American Psychiatric Association. What I have to ask you is, how would you better inform and train those healthcare professionals, those academic, those practitioners to understand the socio-historical and socio-political context of why that systemic racism even exists?
Yeah, so I think one of the best ways to do that would be to infuse into medical school curriculums some of those types of courses that you're talking about, even if it's just a basic course in African American history, right? Where students would have to learn some of the kind of mainstays in forms of not only medical experimentation against African Americans, but also some of the successful things that African Americans have done, back to Dr. Hicks' point, for various forms of community health activism, right? So I think the best way to do that would be to not only educate medical students as they're in school, but also to have them do perhaps some type of field clinical experience in various different types of African American communities where they are actively engaging some of the contemporary ways in which we see the manifestations of systemic racism in health, right? So whether that is in absence of accurate records about communities, right? Or whether that is if you're exposed to certain toxins in your communities, right? So having some type of field clinical experience where students actually are engaged in those communities and not coming in with this kind of position of medical authority, but rather thinking about it more in terms of collaboration, so that it's not just you're learning this information in school, but you see the ways in which we still have the real manifestations of racial bias, particularly in the entity of healthcare.
Absolutely. So Ms. Blake has already touched on a bit of some of the historical instances in which Black communities have essentially been used as guinea pigs for healthcare purposes and research purposes. We are very familiar with the story of the Tuskegee experiment. Most people are very familiar with the story of Henrietta Lacks. Some of the stories that Ms. Blake also shared in regards to forced sterilization, the research that we know was conducted forcibly on Black female slaves that informs the foundation of OBGYN field. A lot of times we talk about these things as though they're historical. What are some of the present day injustices that you're already seeing take place or currently seeing take place that may not be to the same level and the extent of these experiences, but are still giving rise to disparities in regards to care? And that question can go to anyone.
I would say that one of the major issues, a lot of these environmental justice issues, right? Areas where there has been dumping, like for instance, in parts of Texas, right? Where we know there are all of these forms of toxic waste being dumped in neighborhoods, producing cancer amongst various populations, or there's all of these different cancer cells that we see also connected to cell phone towers as well. I think the in parts about environmental justice, right? So clean water, clean access to clean water is definitely an issue. And as always, with the issues of asthma, particularly in urban areas, where we still have a lot of buildings that still have lead paint and those types of things. So those are kind of like the big three. But then definitely when we think about reproductive rights, there's been a lot more attention recently because of celebrities, right, who have been more vocal in talking about their experiences of not being viewed as human or visible, right? Kind of some of the same things you referenced before with the foundation and creation of modern obstetrics, with the work of people like Deidre Cooper Owens and others who have really drawn attention to that longer history of why we see a Serena Williams going to deliver a baby and she's not being heard in terms of talking about her own medical condition and the need for various types of medication, right? So when we look at the mortality and morbidity rates of Black women in particular, I think that is perhaps one of the most significant, in addition to those environmental justice issues, ways in that we see this kind of replication of a kind of dehumanization of Black bodies and Black women's bodies in particular.
So one of the themes I feel like I'm hearing in everyone's response is the need for more education, right? Education of our healthcare providers, education of community members, so that they themselves can be empowered to prioritize their health and know how to locate and identify a culturally responsive healthcare professional. What I'm also hearing, though, is a need for more context in what it means to do health outreach to Black population. So, for example, when you think about health disparities and you think about healthcare challenges and lack of access to care, oftentimes we're thinking solely about the symptoms. We're not necessarily thinking about the environments and how systemic racism impacts healthcare because of some of the things that you just mentioned, access to water, and some of the other things that may not have mentioned is access to a healthy street, access to housing, access to foods, access to certain things. And systemic racism is kind of built into all of those things. What are some of the examples of systemic racism that you believe need to be addressed in order to enhance healthcare?
Or can I just add? I'll just add on top of the earlier comments. What we're getting at is the social determinants of health. We give examples of the built environment. So physically, where people live impacts health outcomes. We can't disconnect the historical legacy of redlining and how do people get to where they are at. So I think that we have to recognize the past and that the past is still going on in the present. How do you deconstruct a system that has been set up this way for hundreds and hundreds of years in our country is going to be important. And it's not only just the built environment, it's the education system. It's the healthcare access. If you have access to insurance, you have transportation, do you have gainful employment? So traditionally we would think that, oh, that's not really related to healthcare. It absolutely is. It's not about a genetic predisposition to anything. It is a result of the systemic processes that were put in place to let one person win and another person not win. So we have to change from our standpoint and our lens of how we view everything. It has to be a paradigm shift. We need to have an equity lens, recognizing the historical wrongs and ills that still are pervasive today. And then how do we get to those fundamental human needs that we still have disparities in? And until we start getting to those really fundamental core issues, we're still going to have these persistent disparities where we're just basically getting low-lying fruit out, but we're not addressing the roots of the tree. We're just trying to talk about the fruit that we've been talking about for the past 50 years.
I appreciate that perspective so much. I do want to acknowledge and then ask another question. From what you're saying then is that healthcare professionals right now are dealing with the byproducts, right? They're dealing with the roots or the fruit of the systemic inequity and the systemic racism that's built into a lot of these industries and that we have to engage with all the time. Who then is responsible for uprooting those systems? Because that is an all hands on deck issue that we need to address. Is it elected officials? Is it healthcare professionals? Is it community members? What does it look like from each of your perspectives for us to have a universal kind of approach to addressing some of the systemic racism that's embedded into healthcare, embedded into education system, embedded into the criminal justice system, embedded into our economic system that's giving rise to these communities that keep some unhealthy?
I think it's all of our responsibilities, right? To dismantle and overcome racism in health. Currently, this pandemic has really put a spotlight on public health, on medicine, on people who work in these spaces. And it's really required us to work across disciplines, really, to collaborate and really center health equity, as Dr. Hicks has really mentioned and alluded to. And I feel as if right now there's a lot of money being invested from public health organizations and agencies to really, one, truly understand what racism looks like and how it really affects public health, to really establish collaboratives that are not just worried about implementing programs, but really come up with recommendations that affect policy and policy changes. And lastly, I think there is something to be said by just simply acknowledging the social determinants of health, the health inequities that we have, so that we can better promote what we know to be a problem. And we can do that by really visualizing it, verbalizing it in a way so that we all know how to tackle it.
So perhaps maybe one of our challenges is that in the backdrop of our most recent racial and political climate, when you think about the division that has taken place in discussions related to the Affordable Care Act, into the expansion of Medicaid, Medicare, how can we make better strides in regards to addressing health disparities and social determinants of health when those conversations oftentimes are so politicized? And maybe Dr. Shakur, that might be a really good question from your wheelhouse as someone who's operating in the Department of History and Political Science.
So I think that's a very complicated question, because we're thinking about how do we galvanize people from different backgrounds around the issue of health, right? And so if we think historically about some of the things that have worked, it's been to kind of look at the commonality between, I'm just thinking here about, like, say, reproductive rights, right? So to look at some of the commonality across racial and ethnic groups, but then also to look at some of those differences and how those things can inform policy, right? So although we might have common issues, we might have different issues about different positions about other issues, and that incorporating those leads to a more powerful movement. I think in our current political landscape, because there's such polarization, achieving that unity around, and I hesitate to use that word, but it's achieving a more kind of equitable and palatable shift in healthcare, I think is really a challenge. One of the main things that we do continue to see, however, is because of, particularly in the COVID landscape, the rise of a lot of these kind of virtual spaces, right? We do see, I think, an increase in efforts to try to unify around various health issues, right? But if we're looking historically, there's always a challenge when you're talking about politicizing healthcare, even though we know that this dates back to, at least the progressive era, right? And some would argue even earlier.
So because the topic of health disparities is so massive, so wide, so inclusive, and so involved, and when it comes to the experiences of Black populations, if you had to pick the top 3 systemic racist health disparities that exist right now in the Black community, which of those 3 would you pick, and how would you address them? And that's for anyone.
I kind of made reference to that before when I was talking about this issue of reproductive rights, right? Like, how do we aid and try to reduce high levels of mortality and morbidity amongst African American women? But this is, again, connected to broader issues of essentially a denial of the ways in which practitioners oftentimes think about the ways in which Black people experience pain or do not, going back to that John Henryism example that we mentioned earlier. So definitely reproductive rights. And then again, some of those issues around environmental justice, I think are really, but again, it's all going into, how do we essentially unpack, what is America, right? I mean, it's a very daunting task.
Dr. Richardson, I would add on top of those kind of maternal mortality issues is infant mortality. That's something that we've had this issue forever in this country, and even though the gap between, say, Blacks and whites infant mortality has narrowed, it's still unacceptably high. When we have pockets in the United States where the infant mortality in certain pockets of the U.S. rival the most poorest parts of the world. And so, so then the question is, well, how can we still have that issue? Because I'm and there's lots of different issues we could tackle, but with infant mortality, this is the starting of life in our community. And that, to me, that's a multifaceted approach. It's educating that expectant mother. That's making sure that expectant mother has all the social supports and resources to be able to have that newborn child off to a great start, wrapping around all the types of resources that you can, and still addressing all those basic human needs that you need for survival. So you got to now take care of not only the expected mother, but you have to take care of the child that's to be born as healthy as possible. So I think that's at least another key one that we should definitely put focus on.
Yeah, and I definitely think when we're thinking about infant mortality, like for instance, here in the Panhandle of Florida, there are very few hospitals in a lot of the rural areas. So, like, although Tallahassee is the capital of Florida, you drive probably 30 or 40 minutes from here, and there is no hospital, right? So when you're thinking about infant mortality, this question of, what actual hospitals or medical facilities do you have in your area, particularly if you live in largely rural or agrarian areas, and then how that feeds into all of these other issues of health care, because you don't have medical care, right? This is one of the issues that's been addressed with Moral Mondays, right? And some of you may be familiar, and with other in other areas. I know here, particularly in the Panhandle, there has been a lot of activism to try to, particularly in Black communities in Gaston and Jefferson County here in Florida, to try to get more medical facilities that are specifically geared to infant health and also mothers as they are preparing to have labor and delivery.
I just want to add to the really impressive list that we just mentioned. I think mental health goes without saying, especially with the Black community. We struggle a lot with just addressing it as an issue, one, but also embracing and taking into account the effects of racism on our mental health is another issue. So in order for us to properly tackle racism and its effects on our health, we have to think about what it does to our mind and how that affects how we treat ourselves, how we interact with health professionals, and also what decisions we make for the healthcare that we choose for ourselves as well.
Absolutely. And I actually think that goes very much with what Dr. Shakir was saying earlier about it being very much tied to our history, because the idea that racism impacts us psychologically, these are not newer conversations. I know the concepts related to post-traumatic slave syndrome, racial battle fatigue syndrome, activism burnout, all of these things that we're seeing in regards to Black mental health, these are newer terminologies, but W.E.B. Du Bois, Sojourner Truth, they were talking about this psychological exhaustion in the 1800s. So in a sense, it's not necessarily anything new in regards to the Black experience of living in an environment where racism is a part of our day-to-day interactions. With that being said, and I hope I don't get too controversial, but this is the BCRI and we should be able to talk about these things. When we talk about having to uproot the history of our country in order to have honest, intentional conversations about why these systems of inequity and systemic racism is embedded into our healthcare systems, it really is going hand in hand with how the concept of critical race theory is being politicized, right? The same ways that kind of theoretical framework gives rise to authentic and intentional conversations that acknowledge our true history. We can't have those education of the healthcare professionals without acknowledging fully our histories. Do you see that connection in some of your work?
Yes. And I think at least for me, I take a more global approach to this critical race thinking. I think it's really important for Black people in particular to understand that our history doesn't start with slavery. And that helps us know that we can overcome a lot of different things. But when we start at slavery, right, in this country with our history, it puts a added burden that we already are experiencing in trying to overcome. So with the work that I do, not only as a director of health equity for a national organization, but also as a researcher and as a student, a doctoral student at the University of Alabama, Birmingham, is that I try to make sure that people, especially people of color, have a complete understanding of what their history is, how it's connected, so that they can make the best decisions for their health. And that when we have a better picture of what we're working with, when we have a more holistic picture of what we're working with and what we need to do, we make better decisions. So.
Absolutely. So, research from the US has documented disparities across race and ethnicity, especially as it relates to immigrant status and even language proficiency, and how that impacts insurance status. So, what are some of the resources for accessing affordable insurance that you would recommend to someone who may find themselves without access? Anyone? That question can go to anyone.
Well, I will say this, and this is across the United States. One of the primary mechanisms that the federal government at least has used as putting resources into community health centers. So you have there's federal grants going to community health centers in rural and urban parts of the country, and they are providing just irrespective of your ability to pay, and so I think supporting that system is helpful, because in fact, because they get federal dollars, you don't have to worry about someone's citizenship status. They're interested in your health, and that's it. So I think that there are those resources out there, but of course that's not enough. Mm-hmm. But certainly, I think that not like I'm here in the state of Alabama. In Alabama, we've talked to our Hispanic and Latino Latinx partners, and they talk about the fear that people in their community have just accessing institutions, because they said, if I go there, are you going to ask me a bunch of questions? Are you going to ask me about, do I have an ID, that I may not have this certain type of identification? Are you going to report me to the government? And so that in and of itself, that fear then dissuades people from accessing even some of those resources that are out there. So we first have to find out where's that trusted network of resources that have been vetted, vouched by the stakeholders, the groups that we're trying to engage with. And then how do we make sure people get connected to those resources? And then how do we make sure those resources are sustainable long term?
Yeah, and that's one of the issues we definitely have here in Florida. We have a lot of support in terms of community health services, but to Dr. Hicks' point, the questions about how will I be received or perceived when I come, is this some way to, try to track or document me? That's been a real issue. And then also here in Florida, particularly in the Panhandle, I can only speak to that because that's where I am. One of the issues has been, again, a kind of mistrust about how patients are treated when they actually arrive, right? And so are the people that are working the centers talking about other cases, right, in front of other patients? Or, do community members feel like the center is actually addressing what the health issues are in their community, right? So the center may be set up to address one particular health concern, but the community may be saying, well, that's not really an issue for us. And that's not what we would really like to see these federal dollars addressing, right? So I know here, particularly in Leon County, that has created a fracture, particularly with centers, federal centers that are geared for like HIV and AIDS work, right? That's a really big issue here in Leon County.
So, a lot of what's happening right now in regards to access to media, social media, you're hearing and seeing stories come to light that were not necessarily told and taught in school. You're hearing about Marion Sims, right? And learning about the history of the atrocity of the research that he did on Black female slaves. We're hearing about Samuel Wright, who was the psychiatrist who gave rise to drapetomania, which was a mental health diagnosis that was applied to slaves who ran from their masters. We're hearing these things and we're learning these histories. What role do you believe media has played to really put a spotlight on disparities as they exist in the Black community?
I think it definitely makes it more digestible, right? Because you have these various platforms, right, where you can, splice images as well as audio, and it can be done really quickly using Twitter, right, to do a thread, right? But then that you could also at the same time link within those stories readings that people may want to review to have more in-depth knowledge from just those kind of sound bites that they're getting. I think one of the challenges, however, of using media is that it doesn't always give proper attribution to some of the researchers who have done this work, or it doesn't always give proper attribution to some of the actual patients who have endured these particular health atrocities, right? So I think at the one time it's really good, but I think really it's good to kind of bait people to get them in, but I think having a more kind of complex and nuanced conversation about the relationship between race and health is one of the things I think that we could really grow a little bit in that area.
I think another piece to think about is also the miscommunication that you often experience, especially with the COVID pandemic. The type of information and the type of language that's being used to talk about really complex issues and complex topics have to be much more nuanced, have to be much more um, tailored and intentional. And we sometimes don't see that when we look to kind of traditional media or even social media. So that's another challenge we have to be really mindful of. And as public health professionals, we have to continue to work closely with media professionals and with media companies to make sure that we are delivering and expressing accurate information.
Okay. So, addressing disparities in health and healthcare is important not just from a social justice and equity standpoint, but also for improving the nation's overall health and economic prosperity. So, what are some of the broader implications of addressing some of these disparities that exist within the Black community?
Well, I would say, I think what we all will strive for is that we can leave a legacy for future generations, and we all hope that we will sacrifice, hopefully, for our children and our grandchildren, those that come after us. But if you're not alive long enough to add more into society, that is just an additive effect over time, right? If you're not healthy enough to generate more wealth, because you're sick, you're out, you're on disability, things like that, it's going to have a downstream impact. So, the more that we can make sure there's an even playing field for everybody, it gives everybody the access to building their personal health up as much as possible, and then ensuring that their families are healthy That's mental health wise, that's spiritual health, physical health, and then subsequently, I think it propagates further down the road. And if you use an equity lens, that means that those of us that may have been on the lower end of getting the resources have a lot more catch up work to do. So we need the resources to be more equally distributed so we can have an even playing field so that all of us can realize whatever we call the American dream.
In addition to that, I think it's really important to focus on quality of health. I think a lot of times when we talk about equity, health equity, or social justice, we focus on the outcomes, which are really important. But what's also really important is the well-being of and the quality of life someone lives as well. And by addressing disparities, it helps us start to create lives that we can really enjoy, because now we are healthier. Now we have access and to tools and resources that can allow us to enjoy our lives a lot better.
Okay. We do have one question that's in the comment box. It's from an individual named Corey. And Corey says, I am working on a project regarding health disparities in low-income African-American communities within Jefferson County, which is here in Birmingham, Alabama. My focus is on hypertension. Do you have any suggestions where I can pull data?
What time period are you doing, Corey?
And we can wait for that response.
But I would say that you could look at some of the national health data. But one of the issues with that is if you're trying to disaggregate it by race, it'll just have all Black people lumped together. It's not going to differentiate if these people are born here, if these are people of African descent who are coming from other parts of the world. So that's one of the challenges. I could just be hypersensitive to that because I live in Florida, and that's a frustrating issue. Okay, so 2021, so we're talking pretty recently. So I think you could use some of the national health data, but also your public health department generally will keep some type of demographic data on various conditions, health conditions in your state and in your county. Because I'm not in Jefferson County, I can't direct you necessarily to specific like data sets that they may have, but that's always a good kind of place to start. And then because you're doing such a recent period, 2021, I don't know if you're doing this for dissertation, master's thesis, but if you did have IRB approval, you could also consider perhaps interviewing individuals that about their experiences with healthcare providers in response to the treatment of hypertension, right, in the geographic area that you're looking at. But again, I'm not in any way advising you to just interview random people without getting their consent first and that kind of thing. But again, if you're doing this for a dissertation or master's thesis, I'm sure your advisor has given you direction on getting IRB approval.
I'll just add, as far as the national resources, the Robert Wood Johnson Foundation has good data. And if you're in, I'm in Jefferson County, Alabama, where Birmingham's at. When you're in the larger cities, then the quality of the data is a lot better. You got to be careful. Some of the data is based on surveys. If you really want more really specific stuff, you might have to engage with some of the hospital systems or the insurance providers if they're willing to partner with you on a project. But certainly, locally, we can always maybe chat offline, and I can connect you to some resources.
Absolutely. Well, we only have a few more minutes left in this discussion. I'd like to ask each of you to share any closing thoughts or statements related to oppression and health in the Black community and health disparities. We could start with you, Ms. Blake.
So final thoughts, is that what you're
Yes.
asking? I think I would like for people to kind of take away from this is that this is an ongoing conversation. This is a conversation that we've had for many years, but we all have a part to play in really overcoming and dismantling racism within public health or within the medical field. And it doesn't have to be a grand gesture. You can start small. You can start by really seeking health providers and health professionals that look like you, that understand your culture, that understand your experiences. You can also make sure that you're asking questions and getting clarification on things and health issues that are pertinent to you, and also not being afraid to get second opinions and working with other health professionals to better serve you. Get involved in your community. I understand and I know firsthand that Birmingham has a great community based focused approach to a lot of different issues, addressing a lot of different issues. So really reaching out to communities, really reaching out to community-based organizations that really work on race and race health inequity is a start.
Okay. Dr. Shakir?
Yeah, I would just say start with, educating yourself more about the particular kind of history of this area. Of course, I'm going to say that because I'm a historian. So there are a lot of good books about kind of the history of health disparities, work by Deidre Cooper Owens, Rick Mizell, Sasha Turner. There are lots and lots of books about various aspects. I'm happy if people would like to email me later and ask me. But there are lots of really good books that talk about the history. So then you have some greater context, right? When you are experiencing certain treatment in various medical settings, about the kind of longer history of where that comes from, but then also getting active where you are, right? So there are a lot of really good organizations in that are operating largely from a local level that have a kind of community focus. So I would say getting involved in some of that work so that you are aware of, say, for instance, what policies are particularly being posed in your local or state legislatures that you could perhaps galvanize with other individuals around, trying to change policy, because ultimately that is really one of the major ways that we uproot this systemic racism. Thank you.
Okay. And Dr. Hicks?
Yeah, so, to me, some of the take-home points is this is a very complex issue to kind of deconstruct with multiple layers. When we are suffering oppression, racism, it has mental effects and physical effects, and they're real. And we have to have a deep appreciation of those drivers or influencers, determinants of health outcomes. We have to make sure that we intervene along multiple parts of the continuum, and that intervention is multi-layered. There's policy implications there. There's things that are happening on the grassroots level in your community, in your neighborhood. And we have to challenge the system at all these different points to try to make a more meaningful difference. And we cannot keep doing the same things we've always done. But the first step is to acknowledge that there's an issue and a problem, and making sure we're all on the same page as far as the basics. And I think that's why if we can just elevate all of our IQs with the equity framework of how we just understand how the world is connected, and make sure everybody's on the same page in that regard, then we can hopefully come together to figure out what are those deeper solutions that we have to tackle.
Absolutely. So before we close out, I do want to take a moment to address one more question that was put into the comment section. And it was actually a twofold question. One part of the question is, do you all think racism still exists in medical research? I would venture to say yes. I would think that the difference is that there are greater guidelines that are in place, and there are more guidelines being developed every single day to kind of decrease the likeliness of this. But does it still exist in medical research? Absolutely, which is why we have to remain diligent in making sure that we are putting those guidelines in place and actually making sure that those guidelines are being enforced. It's also why we need to make sure that we have more researchers in place and more diversity of thought and background and opinion and perspective, and that we have ongoing training for all researchers and healthcare providers in regards to their own implicit bias and their ability to provide culturally responsive care. The second part of that question, have all the discriminatory information and textbooks been phased out? I would venture, and I ask that the panelists let me know if they agree with me or not. I would venture to say no, right? I would absolutely venture to say that they have not been phased out. But on the flip side of that, which is a glass half full approach, is to also piggyback off something that Dr. Shakur mentioned earlier, is that there's always new research coming out, and there's new publications, and there's new books that call into account all of that bad information and counters it with accurate representation of history, and more accurate and culturally inclusive and culturally relevant and culturally competent information. So no, they have not been phased out. Yes, racism still exists in medical research, and this is why we all have to remain diligent in our work to address health disparities and racism in our fields as we seek to uproot the systemic racism that is keeping Black populations and other populations ill. So I'd like to thank all of our panelists for being here today. I would like to thank the Birmingham Civil Rights Institute for facilitating this conversation. I would also encourage you to connect to each of the panelists. I know that they are all very available and present on LinkedIn. We are all passionate about this work and welcome questions and opportunities to encourage continued thought in this space. Please stay connected to the Birmingham Civil Rights Institute. And please, I encourage you to do more work in your own personal research to get more versed in this subject matter. Enjoy the rest of your Black History Month. Thank you so much to everyone.